Hello, my name is Hussam Yacoub, one of the vascular or stroke neurology specialists with the Lehigh Valley Physician Group. Today I'm going to talk about the RACE evaluation form and its benefit in evaluating patients with acute stroke in the field. It can be a challenge in the field to differentiate a patient with an acute stroke having a large vessel occlusion or clot versus not having a large vessel involvement. And this is what we're going to talk about today. In this coming summer of 2017, we will see some changes in the protocol of assessing patients with acute stroke. For example, the window for activating a stroke alert for a patient with acute stroke symptoms will be extended to 12 hours. Another addition which I will be expanding on today is known as the RACE evaluation form or scale, which will be added to the originally known pre-hospital Cincinnati stroke assessment form that we've known of in the past. The RACE test evaluation form, or the rapid arterial occlusion evaluation form or scale, has several components. We start with the basics. First, we evaluate the patient for the presence of facial weakness. We ask the patient to smile, show all their teeth, so on and so forth, and we do give a grade of 0, 1, or 2. 0 for no facial weakness, 1 for mild facial weakness and document the side, and 2 points for severe facial weakness. Then we do what we did with the initial pre-hospital stroke evaluation. We examine the arms for weakness. We can ask the patient to hold each arm individually and in the air for 10 seconds and look for a drift or look for obvious weakness. We do that on both sides, or we can even ask the patient eventually to hold both arms and look for any asymmetry. We give a score of 0 for having no weakness, 1 for having mild to moderate weakness, and 2 for severe weakness or paralysis. Then we repeat the same thing for the leg. The patient will hold each leg individually in the air for 5 seconds, and then we look for any drift or weakness or paralysis. The leg score is the same as the arm. We give 0 points for no weakness, 1 point for mild to moderate weakness, and 2 points for severe weakness or paralysis. Now, these are findings that could be seen with small strokes or strokes involving small vessels. So how do we differentiate from patients having large vessel occlusion? This is the benefit of the RACE evaluation form. The next thing we look for is what's called gaze deviation. Patients with large vessel occlusion and large strokes can have what's called gaze deviation. The patient's eyes will be gazing to one side versus the other. Typically, a stroke patient would look towards the side of the brain having a stroke and away from the paralysis or weakness side. Presence of gaze would increase the probability of having large vessel occlusion, and the patient will get 1 point. Absence of gaze deviation, the patient gets 0 points. Next, we look at what's called aphasia versus hemi-neglect. Patients with left-sided brain stroke due to large vessel occlusion can have what's called aphasia, or difficulty with language. We assess for aphasia by assessing the 3 basic components of language evaluation, which would be naming. We ask a patient to name a simple object like a pen, glasses, or a photo ID. Repetition, by asking a patient to repeat a word or a sentence, and comprehension, by asking the patient to follow commands. Show me 2 fingers, close hand, open hand, so on and so forth. If a patient has right side weakness and aphasia, the patient most likely have a large vessel occlusion. Patients with right side brain stroke will have left side weakness, but will also have what's called hemi-neglect. A patient would be gazing their eyes to the right side of the brain where the stroke is occurring, and therefore having what's called inattention, hemi-neglect, not paying attention to the left side surrounding, not paying attention to the weak side. Patients can have severe hemi-neglect to a point that they will deny the ownership of their own limb, another thing that can be also assessed in the field.
Whose arm is this?
I don't know.
So in summary, the presence of weakness would indicate a stroke, but on top of the weakness, the presence of a gaze deviation to either side, left side gaze deviation with aphasia, or right side gaze deviation with neglect would indicate a large vessel occlusion, and the patient in this case should be transported to a comprehensive stroke center for mechanical thrombectomy and other treatments. We have known for several decades about the benefit of giving IV TPA or the clot buster to patients with acute stroke in the hospital for several years. In the recent few years, we have learned more about the benefit of further treatment with a method known as mechanical thrombectomy, where we reach a clot inside the brain with a catheter to further help a patient with acute stroke. If you assess a patient in the field and you use the pre-hospital Cincinnati form and find the patient is most likely having a stroke, now you can go a step further and evaluate using the race evaluation form. And this will help differentiate which patient has a high probability of having a large vessel occlusion versus not. There has been several studies or trials published recently in the Stroke Journal confirming or evaluating the benefit, showing the benefit of the race evaluation form. The benefit of which is differentiating patients from large vessel occlusion versus none, which will help EMS in the field triage patients and evaluate who would be transported to a primary stroke center, who would be transported to a comprehensive stroke center.